All right, class, so I'm at the Virginia Beach Conference, which means I'm not there, so y'all don't have to put up with me, but you do have to put up with my lecture, huh? So last class we talked about how to read the EKG strips, and we went over the different atrial dysrhythmias. And those are dysrhythmias where the impulse actually starts in the SA node, which is the, natural pacemaker of the body. Well, if the SA node were to not be working properly, the backup pacemaker would be what's the second spot it goes to? The AV node. So this chapter, chapter 7, deals with dysrhythmias that would happen if the SA node wasn't working and instead the firing was starting in the AV node. So, don't forget to pay attention to Mr. Wahlberg up there. So, normal heart rate is 60 to 100, and that's when the impulses start in the SA node. However, we are focusing today on impulses that start in the AV node. Because it's starting in the AV node, it's slower. So the heart rate is going to be 40 to 60 instead, whereas before it was 60 to 100. Because it's starting in the AV node, it's slower to fire, slower to get started, therefore the heart rate altogether is slower. Also, the P wave, which should usually be up on a normal EKG, is going to be inverted or negatively deflected. So when a P wave is negatively deflected, or you can't see it at all, that automatically lets you know that it's not firing in the SA node, it's firing in the AV node. So with the SA node being the main pacemaker of the heart, the AV node is the backup pacemaker of the heart. And when it becomes the backup pacemaker and it's actually the one initiating the electrical impulses, we have dysrhythmias known as junctional rhythm, accelerated junctional rhythm, or junctional tachycardia. We're going to talk about all those. So what exactly causes that inverted or negatively deflected P wave found with junctional rhythms? The fact that the impulses are starting not in the SA node, but in the AV node instead. And that negative P wave lets you know that electrical impulses are starting in the AV node, which still leads to a normal QRS wave, and we'll see that as we talk about these different abnormalities. What is the inherent heart rate of the AV node? Remember, normally it's 60 to 100, but since it's starting in the AV node instead of the SA node, it's usually 40 to 60. Very good. All right, so like I did earlier on Tuesday and with my other PowerPoints, I'm going to put a normal EKG strip on the bottom, and then I'll put an abnormal one on the top so you guys can kind of compare. I know when I was learning EKG, that made it easier on me. So that's kind of how I'm going to present these to you guys. So normal one will always be on the bottom, and then the abnormal one that we're talking about will be on the top. So premature junctional complex. So let you know that there's an early electrical impulse that starts in the AV node. So let's look at these other ones. This one's normal, PQRST, PQRST. This P is negatively deflected. So we talked about that. So that automatically lets me know that this particular heartbeat right here started in the AV node rather than the SA node. And then, of course, it goes on to become regular again. PQRST, PQRST, et cetera, et cetera. But this one in particular started in the AV node, and I can tell that because the P wave is negative or, negatively deflected or inverted. Now, the rate is still pretty regular, though. Look. Boom, 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 boom. So the rate here in this example is pretty regular. However, it could cause it to be irregular just depending on how bad the premature complex is. So P wave, the early beat, is going to be inverted. It could proceed, follow, or be buried in the QRS complex. So in this, we clearly see it, and then there's the QRS complex. But sometimes it could actually be hidden in the QRS complex. It really just depends. You'll see some of those here in a minute. PR interval may be shorter than normal or absent. So here we clearly see a PR interval. Here we clearly see a PR interval. But here you can't really see any space between the P and the R, QRST. So PR interval is usually pretty much absent or very, very small. QRS complex, however, is normal. 0.06 to 0.1. So even though the AV node is the one that's triggering the electrical impulse, it's still producing a normal QRS or ventricular depolarization. So those are still going to be normal, and you'll see that in other abnormalities that we talk about too. Usually an isolated premature junctional complex causes no signs or symptoms. The patient is pretty healthy. I mean, you saw the rest of the EKG look pretty good, just except for that one heartbeat that obviously originated in the AV node. However, some might experience hypotension and low cardiac output if they have a lot of these PJCs occurring. So the example I showed you, they just had one, but if they had like 4 to 6 a minute, then they could be showing signs of low cardiac output with the hypotension and the fatigue and the dizziness and stuff. So whether or not they show symptoms is really just going to depend on how many PJCs they have. All right, so tell me, what is unique about the premature junctional complexes? Well, first, the rhythm could be regular, but it may also be irregular. And how's that P wave? It's going to be upside down, negative, or inverted. So inverted negatively. And very close to the QRS complex, so you won't have much of a PR interval. All right, so the premature junctional complex, we had one or a couple of beats that were starting in the AV node rather than the SA node. Now we're going to talk about junctional escape rhythm. All of these beats are originating in the AV node. So look, all of these have negatively defected P waves. See that? All of them are negative. So that lets me know that all of these beats are originating in the AV junction and the AV node, and the SA node is not firing at all. This still produces depolarization of the atria like it's supposed to, and it's still going to lead to a pretty normal, healthy looking QRS complex. So you see the QRS complexes still look really good. The PP and RR intervals are still regular, so let's look back. See, it's still a nice regular rhythm. But remember, those PR intervals are very short. Look how short this PR interval is. It's extremely short, so notice that. And remember, with normal SA node firing, the rate is going to be 60 to 100. Now with these junctional escape rhythms, since it's firing from the AV node, it lowers our heart rate, and our heart rate's going to be 40 to 60. And we can see that clearly with this 6-second strip. They do have a low heart rate. P wave is going to be negative. Like I said, all of these are negative. It could actually be so close to the QRS complex that it's invisible. Now, these were visible, but we're going to see in other abnormalities that you can't even see the P wave because it's so close to the QRS complex, it kind of falls in it. Once again, that PR interval was very, very short. So it's supposed to be 0.12 seconds, but you saw how close it was. Very, very short. And we'll see in other abnormalities that we'll talk about that sometimes it's so short you can't even measure it. And like I said, the QRS complexes still look very normal. So they're still 0.06 to 0.1 seconds like they should be. Now, these patients, once again, have the slower heart rate, so 40 to 60, which is definitely going to lead to cardiac output. Once again, signs and symptoms of that, hypotension, confusion, disorientation. This is definitely something that needs to be reported to a doctor immediately. Okay, so if you have a patient and every single beat that they have has a negatively deflected P wave, that lets you know their SA node is not firing at all whatsoever. So you have got to let a doctor know immediately so the doctor can jump in and intervene, especially if it was something that was not previously noted on previous EKGs. All right, so tell me, what is unique about these junctional escape rhythms? How is the P wave? It's going to be inverted or negatively deflected. And remember, it could be so close to the QRS complex that you can't even see it. So we could see ours, but I'll show you some here in a second. All right, let's move on to accelerated junctional rhythm. So with the junctional escape rhythm, we've got a low heartbeat, 40 to 60, because it's originating at the AV node. Well, accelerated junctional rhythm, because it's happening, at the AV node, we would still expect that low heart rate. However, it's almost like the heart is trying to make up for it, so it accelerates it. So we're going to see a little bit faster heart rate with this one. But like I said, it's still originating at the AV node, which means you're still going to have those negatively deflected P waves. However, atria are still going to depolarize like they're supposed to, and it's still going to stimulate depolarization of the ventricles like it's supposed to, leading to the QRS complexes. It still usually shows a regular rhythm, so PP and RR intervals are regular. Once again, if the P wave is hidden in the QRS complex, you might not be able to do the PP intervals. Now, Remember, with our junctional escape rhythms, our heart rate was 40 to 60 because it's starting in the AV node. Well, these are also starting in the AV node, but it says it right there. It's accelerated. So once again, the heart is kind of working in overtime to make up for the fact that it's firing from the AV node rather than the SA node. So the heart rate is instead going to be normal, 60 to 100. Okay? Our bodies are pretty smart. They do actually try to make up for abnormalities and issues when they can. If you can see the P wave, once again, it's going to be upside down or negatively inverted. Could fall within the QRS complex where you can't even see it. PR interval is going to be very short again. And like I said, you might not even be able to determine it if it falls within the QRS complex, but if you can see it, it's going to be very, very small. QRS complex is still going to be normal though. Remember, QRS complex represents depolarization of the ventricles, and that's still happening like it's supposed to, so that's still going to be normal. So things you need to remember, P wave will either be inverted, negatively deflected, or it could be absent altogether if it's hidden in the complex. Very unlikely that the patient will show signs of low cardiac output with this because remember, their heart is working overtime to have a normal heart rate, 60 to 100. So they're actually getting the cardiac output they should. However, every single beat is originating in the AV node, and you know that because all the P waves are either inverted or hidden in the QRS complex. So once again, because the SA node is not firing at all, you still need to report this to the doctor. Even if they have a normal heart rate, even if their cardiac output is great, the SA node's not firing, and the doctor needs to know that. So this is still something you need to report. And here's a picture of it. So down here's your normal one. And once again, you see where your P wave should be, it's negative, and it's kind of hidden with the Q that starts the QRS complex. There's your T. You can see your QRS and your T's, but see how the P is kind of hidden with this negatively deflected part of the QRS complex. So, and all of them are like that. See, all negative, all kind of buried in there. So, like I said, you would definitely be reporting this to the doctor. All right, so what is unique about this accelerated, junctional complex? Well, once again, the P waves are either going to be inverted or hidden in the QRS complex. What is your heart rate going to be? 60 to 100, so it's actually going to be normal. Accelerated, it's making up for it. PR intervals will be either very, very short or non-existent. All right, so we did the junctional escape rhythms, the accelerated junctional rhythms. Now let's go to junctional tachycardia. Well, tachycardia means rapid heartbeat, okay? So heart rate is going to be even faster with these patients. Once again, though, it is a junctional rhythm, so it's originating in the AV node rather than the SA node. However, it's still going to depolarize the atria just like it should. It's just going to be a negatively deflected one. And it's still going to cause depolarization of the ventricles. So your QRS complexes are still going to look pretty normal. PP and RR intervals are going to be pretty regular, pretty similar. If you can see the P's, then you can try to measure the atrial heart rate, but PP might be hard to see depending on whether or not you can actually see the P waves. Look at the heart rate on this one. So with the junctional escape rhythm, our heart rate was 40 to 60. With the accelerated junctional rhythm, our heart rate was 60 to 100. With the junctional tachycardia, it's 100 to 150. That is extremely tachycardia, okay? So very, very fast. P wave, once again, it'll be inverted or it could be, hidden within the QRS complex. You might need to increase paper speed on these patients. Remember, their heart rate's 100 to 150, so to get a nice, good, clear picture of the EKG strip, you're probably going to have to increase the paper speed. PR interval will be very short. You might not even be able to see it, depending, if the P is hidden within that QRS complex. QRS duration, once again, though, the ventricles are depolarizing just like they should. So the QRS is going to look pretty normal. Nice 0.06 to 0.1 second duration. With these patients, because their heart is beating so fast, a lot of times they will complain of having like chest palpitations or heart flutters. If they recently had an MI, and an MI stands for myocardial infarction, if they recently had an MI or heart attack, this is definitely life-threatening, like urgently need to intervene. However, either way, you're going to, whether they recently had an MI or not, you're still going to report this to a doctor because their SA node is not firing. Every single beat is starting in the AV node. So it's still something that's going to have to be reported to your doctor. Okay. I'm going to have a picture of junctional tachycardia. So once again, you see the rhythm. It's a lot faster. Down here's your normal one. You can't even see the P's. The P's are hidden in the negatively deflected Q's. So P, Q, R, S, T. P, Q, R, S, T. P, Q, R, S, T. So, and you see how much faster this rate is. Okay? But once again, all the P's are either hidden or negatively deflected. So that lets me know that everything is starting in the AV node. So definitely reportable, or definitely must be reported to the doctor. Okay, what is unique about the junctional tachycardia rhythms? Well, remember, the P wave is either going to be inverted or completely missing. And what is your heart rate going to be? 100 to 150. Excuse me. Okay. Now, let's move on to supraventricular tachycardia. As you can see, this one makes it very difficult to see anything, even the P, the T wave, anything. Now with these, once again, it's very possible that the heartbeat is starting in the AV node. Or, since we can't even see P waves at all and there's no negative deflection, you know, it could be starting in the atria themselves. So the actual atrial tissue could be starting the beat. So it's either going to originate from the atria or the AV node. Okay, we can't really tell, unfortunately, because of the way the strips come out. So it's usually regular, so let's look at this. Pretty regular rhythm, okay? P waves are usually regular if you can see them. You couldn't see them on our example. Look at the heart rate now. So junctional escape rhythm, we had a heart rate of 40 to 60. And then accelerated junctional rhythm, we had a heart rate of 60 to 100, nice and normal. Junctional tachycardia, we went 100 to 150. And now with supraventricular tachycardia, we're doing 150 to 350 beats per minute. That is crazy. Okay, very, very, very fast. And then the atrial rate, which, remember, we count the R's for the ventricular rate. The P's is what we would count for the atrial rate, but you can't even see the P's. So the atrial rate, we're probably not going to be able to determine. Okay, P wave, usually you can't even see it. So it's usually unidentifiable. It's usually hidden inside the T wave. Let's go back and look at it. So, can't get my picture to come up now. Well, anyway, it's hidden in the T wave. P wave may occur before, during, or after the QRS complex. PR interval, you couldn't even see the P wave, so you're not going to be able to determine that. But remember, our QRSs are still normal. It's still triggering the ventricles to depolarize like they should. So the QRS duration is still 0.06 to 0.1, so it's still nice and normal. With these, we can see these on both stable and unstable patients. We like to call stable patients like walkie-talkie patients. They just come in walking and talking to you. I've seen walkie-talkie patients that demonstrate supraventricular tachycardia. I've also seen patients who are inpatients at the hospital demonstrate this. So they could be a patient considered to be in stable or unstable condition. Either way, you're going to monitor them for the signs of low cardiac output. So the hypotension, the dizziness, confusion, things like that. And remember, there are no positively deflected P waves. Everything is letting you know that the SA node is not working. So that means that you're going to have to report this to a doctor. Okay, so observe them for low cardiac output and definitely notify a doctor. All right, where in the heart does a supraventricular tachycardia originate? Now remember, this is kind of a trick question because there are actually two answers to this. We already know that all junctional rhythms are originating in the AV node rather than the SA node, but with these it's so fast it's hard to tell. It could be the AV node or it could also be the atrial tissue. Okay, so either in the atria or in the AV node of the heart. Okay? So remember your law and ethics, evaluating rhythm strips and assessing patients beyond the scope of your practice is illegal. Now, it is you guys' job to get a good EKG reading and good EKG strip on your patient so the doctor can detect any abnormalities. So it's definitely y'all's job to be able to properly record and assess, record the EKG, get a nice reading, good patient care, make sure the patient safely completes the EKG test. It is also your job to be able to detect any life-threatening issues or issues where you would want to keep the patient. So like I said, with all of these strips, except for the very first one, all of them were showing that every single beat was originating in the AV node, or possibly the atria for the last one. But all of them, except the first one, was showing you that all beats were not using the SA node. The SA node was not working. So it would be your job to know, hey, I'm not going to let this patient leave the office. I'm going to let them have a seat and go get the doctor, and they're going to evaluate them. It would not be your job to actually diagnose the patient and tell them what's going on. That's when the doctor would come in. Okay? So there's your Chapter 7, Junctional Rhythms. Yay!